All right, hello everybody. Let me welcome you again today to our webinar summer session, which we again dedicate to the topic of fetal cardiac imaging using MRI. Short note that this webinar, as also the other webinars, will be recorded again. And also again today, it's me, Heide. I'm Clinical Affairs Manager and Customer Relations Manager at North Medical. And Fabian, he's founder and CEO at North Medical. Both of us are happy to lead you today through this session again. And also again, so for those who have joined our webinars, our past webinars, you know already, but I would like to again mention and emphasize that it's our aim to build a community and to offer a platform for networking and exchange. Because as you can see, we have right now already more than 70 SmartSync devices in the market. So more than 70 hospitals working with fetal cardiac MRI. And that's why we believe it's of highest importance to share our information and expertise. That's also why the format today is that each participant can talk and discuss. Actually, we want you to talk and to discuss. So you can raise your finger to show us that you want to speak and we will enable you to do so. You can always ask questions in the Q&A chat function. And also as an information for you, when you have the feeling you need more time after our webinar, just give us a short note and we can stay a little longer and follow on the discussions if the time that we have is not enough. And one new thing we have today in our webinar, we will include some quick polls this time. And those polls are all anonymous, so this is important for you to know. It would be great if you participate in those polls because I think it's very informative for all of us to get some information from you as well. And that's why I will directly now start with the first poll. And I hope you can see it now in your screen, either in your chat function or directly on the screen. The first question I have for you, would you be interested in a forum to exchange about fetal cardiac MRI? You just need to type in yes, no, or don't know, and then send the answer. And I think then it's a new task for us to organize that for you. All right, and I can see now we have 26 answers, and I can see that 85 or 82% answered with yes. So thank you for that. I see that this is of interest, which of course we like. All right.
It looks pretty cool. Yeah, it looks really well.
Okay, so and before we now jump into our topic from our summer session today, I would like just to shortly remind you that we already had 2 webinar sessions this year. It was the kickoff session in January, and in March we had the spring session. Both webinars are online available for recording. So feel free to listen also to those if you have missed it. And there will follow 2 more webinar sessions, one in autumn in September and the other one in December. It's our winter session. And now I'm happy to jump to our session today. It's clinical impact of fetal cardiac MRI. And here we have invited 3 experts. It's Domenico Gulla from North Medical Hamburg. It's Pim van Ooy from Amsterdam University. And it's Richard Friesen from Children's Hospital Colorado in Denver. And before I hand over to Domenico, I have another very important or very interesting question for you that I would like to start right now. And this is, have you or your team already performed a fetal cardiac MRI scan? All right, and here I have now, I'm waiting a few more seconds. I have 22 answers right now. Thanks for participating. I have 27 answers right now, and about half of them did already perform a fetal cardiac MRI scan and the other half didn't. Okay, that's also very interesting and also probably for Domenico, our next or first speaker today of high interest. And with that, I will jump over to Domenico here. He will tell us or talk about what image quality is possible and how to get there, as this is, as you all know, of highest importance in order to do clinical diagnostic with fetal cardiac MRI. We need high image quality, and that's what we want to learn how to improve that from Domenico today. Thank you, Domenico, for being here.
Thank you, Heide. Hello, everyone. So let's jump to my presentation. And this is a brief overview. We are going to talk about fetal cardiac MRI protocols, how to optimize image quality, tips and tricks and challenges, and common pitfalls and artifacts. And then I want to share with you a clinical case study. So let's move on to the introduction. I think that the importance of high quality imaging fetal cardiac MRI is crucial for accurate diagnosis and answer treatment planning, patient and family counseling. And I think it's really important that we need an efficient and flexible protocols. And it's essential also that the technical knowledge during the acquisition. Jumping back the overview, let's go to the fetal cardiac MRI protocols. And here I tried to draw a schematic view of a classic fetal cardiac MRI acquisition protocols. And you can see from the start, from the beginning, from the how to scan the fetal cardiac MRI, and from the maternal localizer, and then going to the fetus localizer in relation to the mother using the T2 single shot, and then the fetus localizer using balanced single shot sequences, and also how to get a faster alternative for fetus localizer using a transversal cine pulse stack. And in this case, then you can get your cine images, your proper cine images. So let's jump to the first topic. In this case, the aim is the positioning of the Doppler ultrasound. And we can use the T2 single shot in transversal stack to understand exactly where is the positioning of the transducer, and to understand if the heart is in the acoustic window of the transducer. And this is important to figure out if the device positioning should be changed. And we need to scroll through the sequences to understand exactly the positioning. Let's jumping back to the review, and then we go, and then after positioning the device, we can easily then have the fetus localizer in relation to the mother in a three-plan view, and always using the T2 single-shot sequences, in this case, axial, coronal, and sagittal. This is a black blood sequences, and it's really interesting because you can see the anatomy and you have an overview of the morphology of the fetus. Jumping back, we go to another important step. It's the fetus localizer using, for example, the balanced single shot. These sequences, it's a sequence white blood sequences, and it's more precisely because you can see exactly the heart anatomy and the morphology, and you can easily plan your following scene more precisely. But it's also really important to understand that depends the timing. Also, we can get an overview of the vessel and also the fetal heart using a transversal pulse stack cine breath hold. In this case, we have two examples of pulse stack cine transversal on 3T MRI scanner and 1.5 Tesla scanner. And why we use this one? Because it's really quick cardiac plan, and it's really useful to plan the following pure plan cine. It means taxis, for chamber view, and two chamber view. Jumping back, we go to optimizing image quality. In this case, it's really important to follow this parameter that you can see in this big table to set up the gold standard cine breath hold sequences. Now, I don't want to go in details for every parameters, but if you need further information, we can contact us, and then also you can find all of the details in our fetal cardiac MRI guideline. Then let's go to the tips and tricks and challenges. In this case, we know which are the challenges of fetal cardiac MRI. In this case, I think it's the first one, it's the maternal respiration, but always there are some solutions, like breath hold sequences, breath hold techniques. And then Another challenge is how to deal with a poor breath holder. In this case, we can consider to adjust the cine image parameter and to have also fast image sequences. And then another problem, another challenge is uncooperative with breath hold. In this case, the only thing is to use free breathing sequences. And this is important because we need to understand that the fetal cardiac MRI, it's request an efficient and dynamic scan protocols. And also important that we need also sometimes to optimize the parameter manually. Let's go in details for each challenges. During like the challenges of maternal respiration, it's really important to give the instruction to the maternal to hold her breath and no deep breaths, and then we can run easily our gold standard cine breath hold. For poor breath holding, in this case, we can consider to reduce the scan time per breath hold, modifying the temporal and spatial resolution, and also we can use also parallel imaging or acceleration technique like sense or compressed sense. In this case, we can decide also to run instead of our gold standard cine breath hold a compressed cine breath hold to accelerate also the scan time of the sequences, and also to consider to have a cine breath hold with low resolution. Regarding the uncooperative with the breath hold, in this case, it's important to give an instruction to the woman to perform shallow breathing, and we can use the cine free breathing using more average NSA from 2 or 4 NSA. Now, let's jump back to the common pitfall and artifact. In this case, it's really important and to take care about the shim box because it's so essential to avoid some artifacts like black bands and also flow artifact. It means that the shim box needs to be in the region of interest for an optimal homogeneity. And also, if we have some artifact from the vessel, we need also to include the large vessel in the shim box. And here you can see how the shim box is in the region of interest of the, in this case, short axis view on the left side. And then here also you can see the 4-chamber view, and in the middle, the first sequences, the shim box was not really fixed in the region of interest. And you can see exactly how change the image quality and the SNR of the sequences. Move on. So another artifact is the wrapping artifact or fold-over backfolding. In this case, it happens because the tissues outside the field of view in fold-over face direction. So the tissues are outside the field of view. In this case, it's important to take care about the field of view, to make bigger, and also to add the face oversampling, and we can also consider to repeat the sequences, change the face and the frequencies direction. Then we can have also... Sorry? Okay, so and then ghosting artifact from motion, in this case respiratory motion. So and then we can consider to repeat the same sequences, just swap the face or facing direction. And here we can have also ghosting artifact from motion, but in this case from the flow. And in this case we can use flow compensation, and always to repeat the same sequences to avoid the problems, swapping face and frequency direction. Now we jump back and we go to the case study, and I want to share with you just cases, and I think here...
Domenico, I have a question.
Yep. Hi.
I am Sameh, from Egypt. Do we have ECG triggering for the baby, or we work real-time imaging?
No. We use the SmartSync, our product. It's Doppler gating ultrasound to synchronize the heartbeat of the fetus.
Okay.
It's not ECG.
Okay.
Yeah.
Thank you, Dominique.
Thank you, Mr. Map. And here, for example, this is a cases of 27 gestational week. So I mean, it's something that it's also possible. And in this case, in the upper view on the left side, you can see that scanning the 4-chamber view, we have a movement. So, and this is one of the problems, the movement of the fetus. And then here the image is bad. In this case, but don't worry, we just repeat the same sequences, and then we can see that we can see the 4-chamber view, but also we can understand that maybe there is something to change in the parameter. In this case, also there are, I think, noising, and also maybe the mother, the breathing of the mother was not really good in this case, and that's, I think, adapting this parameter, no, and then to give some instruction to the mother, and also to fix the shim box in the really region of the interest. You can see that in the third images, it's perfect, and then it's, I want to repeat that it's just 27 gestational week in this case. So, and continue with this spatial resolution, with this image quality, we just decide to continue to have an overview of the arch, and maybe also of the short axis view. And we tried also to tilt the packaging to exactly have a better, and here you can see it's more slices, it's 5 or 4 slices. And I think in the last images you can see better the arch, and then also a stack of short axis. Yep.
Great, thank you,
That's all.
Domenico.
Yep.
Do you have any question? Thank you, Domenico, for this very good overview. I have to mention that was a lot of information now, probably for most of you. Whenever you have questions or you want to go into detail, or you didn't understand something, just send an email, call us, whatever. We are very happy to also repeat it with you in a detailed meeting afterwards. But if you have a question for Domenico right now, that is for the whole community, so also the others can maybe learn from the answer, then you have a chance to raise it right now, or think about it, and you can still ask later. Otherwise, I will shortly now, we will now jump to Pim, who is our second expert, and Pim from Amsterdam. And as Pim is now talking about, or Pim is one of our colleagues or expert that has initial experience with motion-compensated 3D reconstruction of black blood imaging, and of course with the aim to detect fetal CHDs. We have one question for you, for the audience, again, that we would like to share. Pim, before you start, let me just start one of our polls again. So I think that is interesting for you also to get the answers. So the question we have for you is, do you use the black blood slice to volume reconstruction post-processing technique that London has developed? That is the first question here in this poll. And then there's a second question. Do you use the SVR, slice to volume reconstruction, with a North platform? Okay, and this is very interesting because I have right now 25 answers. There's 40% each for yes, and also about 40% for no idea what it is, which is interesting. And there is 20% that say no, they didn't use the, oh no, sorry, I'm wrong. Now I'm just at the first one. So the SVR post-processing from London, 45% have used it, 17% haven't used it, and 40% have no idea what it is. And for the second question, there's 27% that have used the SVR with North platform, 32% haven't, and 40% here have no idea what it is. Okay, I think that is highly interesting, and I'm pretty sure that all the people that have no idea what it is right now will be very well informed after the talk from Pim. And with that, Pim, I will hand over to you. Thank you.
Yeah, thanks. Yeah, that's a perfect score for my talk. I was wondering if you could all see my slides.
Yeah, we can.
Yes, we can.
Okay, great. So yeah, obviously MRI can be an important add-on in cases of difficult echo. It has many different contrast mechanisms. And here I show a few ungated ones. You can have a T2 weighted black blood imaging or real-time bright blood. You can use the Doppler ultrasound gating device that North developed for 2-day cine bright blood or even for the flow. But now North is also involved in the T2 weighted black 3D reconstruction, which I will be talking about. Obviously, a disadvantage for MRI is that scan times are long, so the baby will move, so we need to think about solutions to compensate for that motion, which will be the aim of my talk today. So this is all based on the seminal paper from London, published in the Lancet a few years ago. What they did is they used a standard T2 weighted spin echo sequence, but they scanned orthogonal stacks over the fetal thorax that were non-isotropic. And they did many stacks, 12. That is a long scan time, but you can also get away with less stacks, which what I will be showing. But the aim of this method is to get isotropic voxels that you can slice any way you want to make a diagnosis of the congenital heart disease at hand. So these images are ran through a very elaborate and complex mathematical algorithms that the London group developed that I'm not going to go into detail because I don't know what's going on either. What I do know is that you have to use a program for this and that you manually have to draw a region of interest to get this motion compensated 3D reconstructed volume that now has an isotropic voxel size and that you can reslice any way you want to diagnose congenital heart disease. So we want to do this method in a multi-center study with all Dutch academic centers. And we have some preliminary results. Actually, it is working quite well in terms of image quality, as we can see here in the top row. Here we use the Philips 3T scanner to visualize the right aorta that you can then appreciate in the 3D reconstruction. So here's the heart, and here is the right aorta. And we have also been successful at a 1.5T Philips in Maastricht. This was a healthy volunteer. You can beautifully see the placenta, the brain, the eyes, the lungs, the heart in all these views. We were less successful at a Siemens 1.5, and that is because we only did one stack of each, and we didn't have slice overlap here. So basically, we just didn't have enough data to get good image quality here. And we did a case on 3T with, on the Philips in Amsterdam, and here, unfortunately, our reconstruction failed. And I will show you why in a few slides. But first, there has been some progress. No longer do we have to draw these regions of interest manually, but AI can do that now. And even better, thanks to the people at North, mainly Kai, he developed a browser version of this very elaborate and complex reconstruction methodology. And now this is easy as pie. You just drag in your data sets. You choose your slice thickness, you choose your resolution, you choose if you want to get an email after the reconstruction is done, and then you click Start Reconstruction. And within 20 minutes, you have your 3D reconstruction without the need for sending data to powerful computers, without running SCP commands in Linux and all that stuff. It's just a very easy, quick to click one-stop shop. You know, I hate the term, but everyone uses it. I mean, it is really that. You only have to click once and it rolls out. So that is super convenient. I tested it if it would give the same results as our manual mask, and it did. I just want to go back a little bit to why this specific scan failed. I mean, at 3T, our scans take ages because we have to limit our SAR. So the TR goes up and the scan will really last long, which is not wanted. So we try to play around with field of views. And then I asked Elena, who has expertise in this method, why didn't we get a recon? Because the body is very cropped. The tool expects full body coverage. So please don't play around with the sequence too much, because the machine learning AI doesn't understand that you were fiddling with the settings. So Elena did it manually for us. Still, it was quite poor quality. And this was a very difficult case. This was a baby that moved a lot. We didn't get the reconstruction done, but still our clinicians were able to see abnormalities on the original data. In this case, the aorta came out of the right ventricle. And this was already seen on echo as well. So that is only a small part of the diagnosis. This is the entire diagnosis of this case. So I was, blown away by this. I just thought there might be a TGA or whatever, but yeah, it was a little bit more complicated than that. I, of course, am an engineer. That is my disclaimer. So the main part here was that it was a double outlet right ventricle. And that confirmed the echo findings. So MRI was useful here. The baby could be born in Amsterdam, didn't have to be born in Leiden, where immediate surgery would have been available. So even when your scan is not perfect, you can have a confirmation or have different findings on the MRI compared to the echo, and this can be important. One thing with the North interface is that there is a slider for your choice of resolution. And if there is a slider, you get itchy and you don't know what to use. So we thought about this, if we could do a systematic comparison for different resolution settings in the reconstruction program. And obviously you can appreciate that the 1.5 is a little bit grainy and that the 0.6 is a little bit smoother. But we weren't sure if there were difference between 0.6 and 0.75. So we'll just be using 0.75, I think, because that is what the Philips scanner gives us back. So thanks, Yat is our student. She did 145 reconstructions with the North interface to look at these differences. So that's great work. I think we're going to go ahead with the 0.75 and look at some cases. So Heidi has prepared the poll, I think.
Yes, I will start the poll for
this is the first case. I have to thank our pediatric cardiologist in Amsterdam, Dr. Sally Kloer here, because she did a great job in looking and understanding these images. So whenever a new image pops up, we're going from left to right. That actually means we're going from bottom to top, right? From feet to head. So this is the heart. You can see a little bit of the septum. There's a left ventricle, there's a right ventricle, and there's a descending aorta. And now if we go up, we see that the pulmonary arteries actually are connected to the LV, right? I hope you all agree with that. And there's a duct here, and the duct, and there's a descending aorta still. And then if we go one more up, we see that the aorta sprouts from the right ventricle. So now the question is to you, what abnormality would this then be? A, an aortic arch with hypoplasia or coarctation. B, a transposition of the great arteries. C, a double outlet right ventricle. D, a hypoplastic left heart syndrome, or E, an interrupted aortic arch.
Sorry for a very short interruption. Maybe you can show it again, because I think because I had the poll highlighted, you couldn't really see the images. Maybe you can just once more, but because now I've submitted, so now it should be visible. Okay.
Yeah, there's the poll. The poll is in my screen, so that is fine. What do you want me to do?
Okay, now you can, yeah, now everybody can see the full screen. Now it's fine. But did you scroll through the images before? Like to the slices, or?
Yeah, you want to see it again? Okay, so here we go.
Yeah, I think it was not visible before. Thank you.
Okay, so LVRV, then pulmonary arteries, descending the duct, descending aorta, and the aorta coming out of the RV. So I'm going to vote the right answer here to be able to see what you guys voted, I think. Ah, there we go. Thanks, Sally. Yeah, I know you know the right answer, so maybe you're not allowed to vote. I see 64% voted for TGA, and we think that that is what that is. So let's go to a next one. Here we see, so this is done, and then there's a new poll coming up, I think, with the same answers.
Yeah, and Pim, you first explain, and then I start the poll, okay?
Cool.
We do that.
Yeah. So here's again a right ventricle, and here's a left ventricle, but there is a kind of a misty white signal over the left ventricle, and the pulmonary veins are really large. So then we go up again. The pulmonary artery exits from the right ventricle, which should be fine. There's a duct, but the duct is really big, and there's a aorta, which is really small. So what do you think? A, B, C, D, or E? There is the poll again. I'm going to vote the right answer. No, I'm not going to do that yet. I'm just going to wait first. And maybe I should give the wrong answer. Huh? Yeah, that's what I'm going to do, the wrong answer. And then we can see what you all thought. And 58% says a hypoplastic left heart syndrome. And we think that that is the right answer because you see that mist over the left ventricle. Basically, there is no left ventricle. I think it must be really small. And the aorta is really small as well. So that corresponds with the HL-HS. Okay, so sometimes you're not able to interpret these images really well. And then what could help is to make a 3D segmentation. That is easily done in ITK Snap. You just put in a threshold, then you put in some balloons or whatever you want to call them, bubbles they call it, yeah, into your segmented space. You grow that and you get something like this. So I presented this a while back. One doctor said it looks like a ball sack, but he wasn't too inspired to look at anything to be able to see here. I think we see a left ventricle here. We see a right ventricle there. There's a duct coming out. One problem here is, of course, you don't know what's left or what's right, and that's really a problem if there could be isomerism. But anyway, if we look at this from a different perspective, then I again have a poll for you, Heide, if you would help me out here. There we go. Is it A, an aortic arch hypoplasia or coarctation? Is it a TGA? Is it a DORF? Is it a HL-HS? Or is it E, an interrupted aortic arch? Can I please have your vote, please? Okay. Thanks. 83% says interrupted aortic arch, and I made these. So these diagnoses have not been verified by a real expert. So I did this really in a messy kind of way. So that's my disclaimer. But I don't see an aortic arch, so it must be missing. So it's probably an interrupted aortic arch. Thank you very much. Then the last one, also based on this 3D segmentation. And also a little bit on the 3D reconstruction. What do you think that we're looking at? Aortic arch hypoplasia coarctation, a TGA, a DORF, HL-HS, or an interrupted aortic arch? Okay, no more answers coming in. So most of you say aortic arch hypoplasia coarctation. I think that's what it is. There is a really small aortic arch here. So I mean, you can interpret these images in many ways. You can look at the raw data, you can look at the 3D reconstruction, you can make a 3D segmentation, and that should all give you a good overview of the congenital heart disease. So we did 30 patients. I think we were successful in about 75%, considering image quality. And we definitely need some more training there. One thing is that we all did this at 3T, but since scans take long at 3T, the chances are also higher that you might get a failure. So we thought it was really useful for the diagnosis of hypoplasia transposition, but also with a closer look for HLHS, even Dorf we thought we saw, and maybe we even see septal defects. Even though before we didn't think we could see intracardiac abnormalities, but here we do think we see a VSD. So I made a few of these some of the diagnoses that is really not on, but for this purpose, I think it's fine. It really needs to happen in a multidisciplinary team with pediatric cardiologists, pediatric radiologists, gynecologists, MRI specialists, etc. We need a clear definition of what's left and right, how we're going to figure that out when you make a 3D segmentation. We will be having some technical challenges considering the use of 3 different vendors and also 2 different field strengths. And the scan at 3T needs to go way faster. And then we need to, if we really want to relate it to echo, it might be useful to get an automated workflow for placing of these slices for interpretation. These are not axial, so this would involve a lot of manual work for the semi-axial ones, or for the coronal ones, or for the sagittal ones. So we have definitely more work to do, and that's going to be exciting for the upcoming future. So with that, I'd like to thank everyone involved in this project, but especially Sally for helping out with these diagnoses. The London team for always providing support for, technically and clinically. And of course, Kai, because Kai, I think you made most of this browser work, which is super helpful and will be very useful in our multi-center project. So thanks for your attention.
Perfect. Thank you so much, Kim, for this very nice illustration. And yeah, thank you to all of you that you participated in the poll. I think it was fun.
Yeah.
Thanks for that. Are there any questions in the audience? Maybe also from those who have already tried the SVR? Okay, there's from Ryan a question for Kim. What criteria do you use to select patients for fetal CMR?
Yeah, that's a good question. So for the research project we want to do, the inclusion criteria is that the baby will need surgery within 1 year of birth, if I remember correctly.
All right. Ryan, do you want to talk and to discuss, or is this fine for you? Okay, you understood. All right. Thank you so much.
What gestational weeks do you include?
Yeah, so this is all 30 plus. Yeah, because the baby is quite large and motion should be theoretically limited because there's not much room to move. But we hope to be able to do earlier gestational ages in the future.
All right, then David Lloyd. David, hi.
Hi, yeah, great talk, Ben. Really nice. I was just making I wanted to make a very small comment about the resolution, the output resolution. So you can essentially improve on the through plane resolution, but there's minimal gains on the in plane resolution. So we acquire at 1.25 by 1.25 by 2.5. When you put everything together, you can get an isotropic volume of 1.25, possibly a little bit above that. If you're going to sort of 0.8, 0.7, you're probably just interpolating. And we sort of had a look at this as clinically as well. It probably looks better, and it's actually probably nicer on the eye. So there's a genuine improvement, if you like, or it's more kind of satisfactory to be looking at images without sharp edges and lines when you're looking at small vessels, but it's probably not actually improving the resolution much beyond your in-plane resolution that you put in.
Yeah, so for the through plane, I totally agree. The in plane, what Philips does is they have a smart sort of interpolation in K-space already. And that seems to enhance the image quality a little bit. So that's why you always need to mention your acquired voxel size and your reconstructed voxel size. But for the through plane, I think that is absolutely correct.
Yeah.
And of course, you cannot push it too far. I mean, at some
Yeah.
point it doesn't add much anymore.
And it takes a long time.
Okay,
It's a sort of logarithmic thing. But I think, yeah, it stresses that importance of the input data is really important. So it's essentially turning it from 2D to 3D, but the quality of your input data is still a really important part of the pipeline, for sure.
Thanks, David.
Right. Thank you for this comment, David. There was Manyar. You also raised your hand. Please just give me a sign if you still want to talk, because your hand is on now.
Sorry, yeah, that's me. No, sorry, my question, I was wondering whether my question would be very relevant or not, but I was just wondering whether, like, with these cases that were shown beautifully, are these where the echo assessment has not been helpful? Do these MRs add any more information from the echo? Or are we still at that stage where we are developing the techniques, and then in near future, we will probably be able to answer questions which echoes, as in ultrasounds, won't be able to?
Exactly, that's an excellent point. So now these patients got an MRI for the purpose of research. It was not so that the echo was not interpretable or anything. We just wanted to make this comparison to see if it's possible to see on MRI what you can see on echo. In the future, it makes sense to, if an echo is inconclusive, to do an MRI, but that's what this research is needed for, to show that this actually works.
Many thanks.
All right. One last question from Michelle. It was already answered by Sally Ann. However, if you want to comment on that, I will read it out. Do you feel venous anatomy is able to be seen on 3D reconstructions? Because this is a question that is often raised for clinicians.
Yeah, that question is a bit too clinically focused for me. I think you can see pulmonary veins, but I don't know what the clinical usefulness of that would be. But maybe maybe Sally can comment, or Richard, or David. Many experts here at present.
Hey, Richard.
Richard, do you want to comment on that, or anybody else?
Sure. Often the venous anatomy can be seen. Obviously, it depends on the quality of your image, how much motion artifact you get. But and in this next case, we'll show that you can see a lot of venous anatomy fairly well by the black blood single shots and through the SVR. So I think in a lot of cases it's been really helpful, and we've had some cases that have come down with heterotaxy and complex systemic venous anatomy and pulmonary venous anatomy that we've done a fetal MRI on and we are able to get a sense of the systemic venous anatomy prior to delivery, and often that can be really helpful in surgical planning postnatally, as sometimes that can be a little bit harder to evaluate by postnatal CT, depending on where you're shooting your contrast. And so it's an opportunity to use a non-contrast technique fetally to clarify that venous anatomy.
Great, yeah. Perfect. I think that was a very good transfer also, and you welcomed you more or less on your own, Richard, now. I pushed you into it. So our last expert today, and it's Richard from Colorado, as I already said. And yeah, as we want to dedicate to clinical impact of fetal cardiac MRI, we thought about having a last question also for you, as this might be of high interest. We want to know, and this is a question that we were always asked, for which kind of, wait, let me just go to the question. 1 second. For which CHD do you believe fetal CMR has a clinical impact? And now you can just put your answers in the poll, and so we can collect those. you should also
cardiac
see
mass is also
in the
interesting.
chat. I give you a few more seconds to think about it and to enter your answers. I think this is of high interest for all of us here to collect these answers.
Probably got everyone like different like
COA coarctation. Yeah.
exactly.
Same
So
meaning, different.
Same meaning, different spelling.
Yeah. All right, you can still continue answering. Richard, we will jump over to you, and Richard will talk about two very important clinical cases today, the impact of hypoplastic left heart syndrome and intact restrictive atrial septum. And now I hand over to you directly. Thank you.
All right, thank you for thanks for letting me talk today. So we will have we'll start with one case and we'll see how much time we have left. This one's a little bit more in depth. The clinical scenario was a 23-year-old who had a fetal echo diagnosis of hypoplastic left heart with mitral stenosis and aortic atresia. But there was also concern with a restrictive atrial septum, and we'll go into this a little bit more. So one of the concerns on the fetal echocardiogram was a pulmonary vein velocity time integral ratio of 2.6. And for those of you who are less inclined in the fetal echo world, I'll go into this a little bit more. But essentially, a ratio less than 5 of forward to reverse flow is concerning for a restrictive atrial septum. They were also seeing pulmonary venous enlargement on the fetal echocardiogram, and then a possible decompressing vein from a decompressing pulmonary vein by echocardiogram that was a little bit unusual and not what they had typically seen in this clinical scenario. So this patient was referred for a fetal cardiac MRI around 29 weeks gestational age, which is right at the lower end of our typical cutoff, which, as Pim mentioned, is about 30 weeks or above to minimize motion artifact of the fetus. But given the clinical scenario and potential for further decision making, this MRI was performed around 29 weeks. One of the clinical indications for this, so even without the cardiac sequences that we do, patients with concern for a restrictive atrial septum in utero are often referred for a fetal MRI to evaluate their lungs for pulmonary lymphangiectasia, which may have a prognosis for outcome if there's abnormal lymphatics and abnormal pulmonary development in the setting of a restrictive atrial septum and pulmonary venous congestion. But in this case, they also wanted a cardiac evaluation to see if we could better understand the venous anatomy associated with this case. So just looking at the echocardiogram, so where we are starting from. So over here on the right, we have patient's left, patient's right. We see a dilated right atrium. We see a tricuspid valve into a dilated and hypertrophied right ventricle with a very hypoplastic left ventricle here. Now we see this very echogenic bright atrial septum, and our pulmonary veins are quite dilated. And when we look at the Doppler, it has 2-fro flow within that. And so a Doppler in this pulmonary vein looked at the forward flow back towards the left atrium and the backward flow, and then doing a velocity time integral, which is essentially the area under the curve, and the ratio of the forward flow, which was about 8.4, to the reverse flow of about 3.1 centimeters, we get a velocity time integral ratio of 2.6. Again, anything less than 5 is highly suggestive of requiring an emergency atrial septostomy postnatally. So this patient fell into that category. As I mentioned, there was this other venous structure bring my laser pointer up. This other venous structure that we saw, so adding color to this, we see our two-furrow flow in our pulmonary veins. We see our descending aorta back here. And then this other venous vessel that coursed from about midline over rightward and then anteriorly towards the region of our superior vena cava, concerning for a possible pulmonary vein decompressing vein. And again, looking at the aortic arch, we also see that there is a hypoplastic aortic arch. And when we look at the color Doppler flow, the majority of it, we see in the descending aorta, there is bidirectional flow that is towards the feet in systole. We see this blue flow in systole, which is consistent with retrograde flow from that ductus arteriosus into the hypoplastic aortic arch. And so as someone who also looks at fetal echoes, I think this is a really helpful thing to do in planning for the fetal MRI, because using these two as complementary imaging modalities, I think is the right way to go. Neither one can be, in certain complex cases, neither one is standalone, but very complementary to each other. So this gives us a little bit of idea of what we're looking at. So quickly, I'll go through our MRI protocol, and then we'll get to some more images. So we start with, as mentioned earlier in this session, we just do axial, coronal, and sagittal T2 black blood imaging of that are oriented to the mother, and this helps us delineate the fetal position, and also gives us another look at the Doppler device location for potential adjustments that we might want to make. We do a balanced FFE of the full fetus to estimate fetal volume and weight. And if we have a good gating signal, we typically jump right into 4D flow to acquire that to assess our flow and physiology. If we need to adjust our Doppler signal, then we may go into the non-gated black blood images beforehand. And then we do our SSFP cine imaging to assess our anatomy and function. Our typical protocol is an axial stack through the entire heart, a vertical long axis, and then a short axis stack. And then we are typically acquire 5 different planes of our T2-weighted black blood images that we use to look at the vasculature and input into the SVR toolkit. So let's look at some pictures.
Yeah, we can see it.
Great. So just a quick look at our axial images. So this is just the maternal localizer. You see her hip bones, bladder. So we come up, we see the baby is head down, and then we start to see the baby's thorax. This is the baby's right. We see our, can zoom in a little bit. We see the right SVC, the cardiac mass, a large ductus arteriosus. These bright images of the airway branching off into the right and left bronchi. And then we see our inferior vena cava inserting in, our descending aorta over on the left side. And we'll see this a little bit more later, but in the region where we would expect pulmonary veins, we see these pretty dilated and engorged venous structures, which we're anticipating based on the fetal echocardiogram. And then coming upwards, see more of these blood vessels that are in a little bit of an unusual location lateral to the rightward of the superior vena cava. And we'll get to a little bit more baby focused ones in a second, but this also gives us a nice look at where our Doppler location is. We felt good with this location. We had good Doppler signal there, and you can see its relation to the baby's heart. Again, looking at the maternal coronal view, as you come out, you can also see the maternal belly button and where the Doppler is in relation to that. So that helps us when we go in the scanner to have a little bit more of a reference point of where we might want to adjust the Doppler if needed. And again, looking at the cardiac anatomy, we see the diaphragm here. We are a little bit more rightward in the baby. We see these dilated and engorged veins in the region of the right lower pulmonary vein. A little bit more smaller vessels going from posterior to anterior towards the SVC, which may be representative of a typical azygous vein, but there are a few other vessels in there, and this particular one that is dilated in the region of what may be an upper pulmonary vein coming back in towards the SVC itself. And again, on the left side, we see the left pulmonary artery quite nicely, and this is the beginning of the ductus arteriosus. So that was our initial look at the maternal localizers. And I will skip to the cine imaging so we can look at the 3D SVR shortly. So this is an axial stack that we start with. We use the localizers and often our 4D flow if we've acquired it beforehand, using that raw image to look at the flow data to adjust our planes and plan accordingly. So we're starting superiorly. We see pulsatile flow likely that we expect from head and neck vessels. This is the innominate artery, and we see a little signal coming out here towards the right subclavian. This is a more anterior venous structure that we'll see will turn into the right-sided superior vena cava. We see our innominate vein coming over here. Two more head and neck vessels, the left carotid and left Enzelf subclavian, and our airway here. You're starting to see the beginning of another vessel coming from posterior to anterior, which in initial looking at this, we said, well, this is probably just the normal azygous vein coming anteriorly towards the SVC. As we continue more inferiorly, we see our pulmonary outflow and our large left-sided ductus arteriosus, our left and right mainstem bronchi, and our SVC here. And we see these vessels more posteriorly, and as we come down, we see this extra vessel where we typically don't see that. So we see our right pulmonary artery and our left pulmonary artery over here, and we see this abnormal vessel that is a little bit unexpected. And in reviewing the fetal echocardiogram, we saw this felt a little bit more consistent with what they were seeing in this potential decompressing vein. So further delineation of that, we were able to see that coursing in the posterior to anterior direction towards that SVC. As we come down a little bit towards the heart, we see the right atrium, a hypoplastic left ventricle, a dilated right ventricle with normal function. And again, coming down, there's a little bit of more artifact and baby motion on this slice, and then we can see our IVC and hepatics and descending aorta coming down a little bit lower. Our vertical long axis, we typically don't have the mom do a breath hold, as we're generally just using it to plan our short axis stack. So you can see that it's not quite as crisp because there's no maternal breath hold involved with that. And then looking at our short axis, so again, we see we're starting more rightward in the baby. We see our SVC and our IVC coming back here, and we see this dilated pulmonary veins consistent with what we saw on the echocardiogram. And then we see, again, this right lower pulmonary vein is very dilated, and the atrial septum is quite thickened, which we generally do not see on our typical CNs with a normal foraminal flap. We see this really thickened atrial septum. Not every image is perfect, but we do see a little bit of dephasing artifact near that descending aorta. And another nice look at our tricuspid valve on FOSS, our right ventricle that is squeezing well, and our hypoplastic left ventricle that does have some cavity to it, but not a lot of inflow or outflow, consistent with mitral stenosis and aortic atresia. So we took one more look at the atrial septum, given the motion artifact, and you can see the just really thickened atrial septum. We couldn't clearly rule in or out a very tiny shunt, but this thickened septum, along with the dilated atria and the dilated pulmonary veins, was concerning for a restrictive atrial septum. So quickly, we'll jump to our SVR. So this is an axial, coronal, and sagittal view. And when we zoom in on this coronal view, we see our innominate vein, our internal jugular, coming down into our right-sided SVC. And as we course a little bit more posteriorly, we see several vessels inserting into that. So this one that appears to come more laterally into the SVC, and another one that comes a little bit more posteriorly, which again may represent an azygous vein, but where we follow that vein down posteriorly, it comes into this confluence that appears to be coming down, that we follow in from those pulmonary veins, with a dilated vessel coursing superiorly and laterally. So coming back here laterally, and then on the sagittal view, we see two separate insertions into the SVC here. So this delineation of that venous anatomy was a little bit more clear on this view, and consistent with what we saw. Furthermore, we see this dilated left-sided pulmonary veins as well. So from those, I will share one more time.
I don't know what's happening here, but something.
It's with the presentation.
I see the presentation now again, Richard.
You do, great.
Richard, you are done, right?
No.
No.
I just have a couple more slides
Yeah,
Okay.
perfect. Yeah.
to show the final
Just
project.
continue.
So
Yeah.
taking that black blood SVR, we didn't reconstruct all the pulmonary veins on this one, but we're trying to sort out the flow. And what we see is that there's a hypoplastic aortic arch represented in red, a large ductal arch, our systemic venous anatomy, and then these two separate vessels inserting into that SVC. So when we add the 4D flow to that, this helps us register. Sometimes it's not entirely clear just from the 4D flow images, so often we will co-register the black blood images with this to better delineate the anatomy. We see these two venous vessels inserting into the SVC, consistent with what we saw by echo and with our other images. With the concern for restrictive atrial septum, by echo, you can see that to-fro flow in the left pulmonary veins. And so we were wondering if we could do the same thing with 4D flow to evaluate more numerically for a restrictive atrial septum. And so we were able to see this to-fro flow in the left pulmonary vein, potentially seeing some flow across the foramen valley, although that was really hard to delineate. So when we focus a little bit more on the left pulmonary vein, we see this to-fro flow, and then quantifying it, we can see the flow rate and time throughout a cardiac cycle and a velocity over time throughout the cardiac cycle to be able to look at the ratio of forward and backward flow. So when we were just looking at flow, the ratio of it, we have forward flow of about 0.17 mLs, backwards of 0.07. That pure forward to reverse flow ratio, we calculated at 2.4. And so by echo, the velocity time integral was 2.6. And so some amount of calculation of forward and reverse flow seemed consistent with what we saw on echo. So we were excited that this may hold some potential in the future for evaluating restrictive atrial septum by MRI. And just another look to bring in our aortic arch view by echo, seeing that retrograde flow. We see the antegrade flow through the ductus, but if you look in systole, these path lines go retrograde from that ductus arteriosus into the hypoplastic transverse arch. And then just to show you postnatally, this had a large decompressing vein that came up and had a tortuous course that had two separate connections into the right-sided SVC. So starting posteriorly, we can see these dilated and engorged left and right pulmonary veins. And then there was this decompressing vein that came up laterally, curved around with a tortuous course with two separate insertions into the SVC. So what we initially thought may have been an azygous vein turned out to be connected to this pulmonary venous decompressing vein. And so we were pleased to see the outcome of this case and got a postnatal CT. Initially, this baby was, the family decided for postnatal comfort care, given the concern for a poor prognosis with the restrictive atrial septum and pulmonary lymphangiectasia. But the baby did well at home for 7 days, and so they called and said, should we do something else? And so they were admitted to our ICU, and after discussions, they did undergo a stage 1 palliation with a Norwood Insano and atrial septectomy, and are doing fine after stage 1 on minimal oxygen and gearing up to go home for the interstage period. So theoretically, that decompressing vein may have been somewhat protective, as their saturations were not significantly hypoxemic after birth, and so having some way for that oxygenated blood to return to the atria and get out to the body, the decompressing vein seemed to be somewhat protective. So that was an unusual case that we had. I will just stop there. We thought it was really helpful to be able to look at the lymphangiectasia, confirm the pulmonary obstructed pulmonary veins, and get an additional view of this potential decompressing vein to add to the fetal echo to better counsel the family, to give them a little bit of better understanding of the baby's anatomy. Theoretically, this could be potentially helpful for consideration of intrauterine intervention, although for most of those balloon atrial septostomies, I believe they're typically done a little bit less than 28 weeks. So that may be a little bit younger than what we're currently doing, but something potential for the future. So I will, similar to what I just said, I want to thank the whole team that we have here, in particular Takashi Fujiwara for the beautiful 4D flow images and analysis. So thanks, and I'm happy to take any questions.
Thank you, Richard. There were 2 questions, but I think they are both already answered. There was Shane Morris. She was asking if the fetus was referred for intervention, but you commented on that and that it would be great to evaluate changes on MRI after stenting. Do you want to add anything to what you said before already?
The idea of an atrial septostomy, I think, was discussed with them at an earlier counseling session when they were at a lower gestational age, I think around 25 weeks. And I think the family thought about it and decided not to go through with that and just to monitor. So I don't think they were counseled on it and elected not to proceed with that.
Mm-hmm. Okay, and then there was Eliano. She was asking for the Weng for 4D flow, but that was answered already, 150 centimeter per second. Yeah. Then there was Mehul Patel. You have a question?
Yes. Thanks for presenting this interesting case. So I had a couple of
questions. Can you increase your sound a little bit? We cannot really listen, or it's too silent.
Sorry, is this better?
This is better. Thank you.
Okay, thanks. Yeah, I had 2 questions. So one is, I'm sorry if I missed this, but what was the result of the fetal MRI evaluation of the lymphangiectasia of the fetus? And the follow-up question is, how did you feel like that was predictive of the baby's clinical state afterwards? Because that sounded like the baby had a little bit of an unusual clinical course and actually did well despite the prenatal suspicion.
Yeah, thanks for the question. I actually forgot to mention that. So interestingly, the pulmonary lymphangiectasia was not as severe as I think we anticipated. And if my computer pulls up, I can show that. So it was a little bit more on the mild to moderate side, and interestingly, the majority of the lymphangiectasia was on the was in the right lung rather than the left, and so which was a little bit more unusual for what we would pull this up. So a little bit more unusual for what we expected with the decompressing vein on the right. And I am not a fetal radiologist other than the cardiac part, so I rely on Lorna Brown and colleagues for more interpretation of the lymphangiectasia. But when we look at at this coronal black blood sequence, we see this hyperintensity more on the right lung than the left, and the left lung actually was felt to be relatively normal with a little bit more moderate lymphangiectasia, particularly on the right. So given the decompressing vein that seemed to be preferential towards the right, I don't know if that is a result of severity of congestion on the right side, but that's kind of what we saw, and so it didn't seem to be predictive so far of their outcome. They have not gone through Glenn stage yet, but did not have a lot of significant pulmonary venous congestion clinically. Postnatally, they did have a small atrial shunt, but it was quite restrictive by postnatal echo. But again, I think a lot of that oxygenated blood from the pulmonary veins was coming back through that decompressing vein, allowing for better systemic oxygenation. So we'll see how they do after their stage 2 palliation in a couple months. But yeah, we've had some cases, and the other one that will present at a future date had pretty significant pulmonary lymphangiectasia. And so the family was counseled a little bit more aggressively with that. But yeah, we don't know whether how predictive this was for their outcome yet.
Thank you, Richard, for this, for answering this question again. All right. Is there any question that I might have missed? Or I know, Richard, you have prepared another case for us today, but we are again over time, and I think we leave it like it is right now, and we can just shift it maybe to the next webinar or whenever.
Sure.
You can share it maybe another time. I know that you have many interesting cases collected already. All right, if there's no question from the audience left, then we would close our webinar session for today. And I think those were very informative and impressive talks. Thank you, Domenico. Thank you, Pim, and thank you, Richard. Thank you all for your participation, also in the polls. I think that was interesting. We will take a look into that again. And yes, we would also like to thank, and don't miss it again, to thank the Fetal Heart Society for sharing before every webinar our flyers, and for sharing the information about the attendance of our webinar. And I think this is great help to even get more people joining and to get even more people connected. And yeah, it's just great to see that the number of attendees is increasing from webinar session to session. And yeah, we are very much looking forward to see you again in September 18th. And again, please let me know when you have any ideas, questions, ideas also for improvement. Any feedback is very, very helpful for us. Yeah, thank you all.
Thanks so much, everyone, and especially for the speakers for preparing the talks. It's amazing to see.
Thank you.
Thank you.
Bye-bye.
Thanks.
Bye.
Bye.
Thank you.